Good morning, everybody. Thank you for joining the meeting this morning. I am Dr. Leanne Godino, physician. I'm lucky enough to be chairing the meeting. And today our presenter is Dr. Festus Iiyambula. He's a very esteemed colleague of ours, and I would just like to go through his bio. Dr. Iiyambula is a distinguished orthopedic surgeon specializing in complex trauma limb lengthening and reconstruction. His academic journey really started with the completion of his Bachelor of Medicine and Surgery at the University of Pretoria in 2015. Dr. Iiyambula's commitment to excellence led him to pursue further education, which culminated in the attainment of his Master of Medicine in Orthopaedics from Sefako Magato Health Science University in 2023. Concurrently, he achieved fellowship status at the Colleges of Orthopaedic Surgeons of South Africa. Dr. Iiyambula's diverse experience includes roles as a medical officer in orthopedics at Mamelodi Hospital and as an orthopedic registrar at Dr. George Mukari Academic Hospital. During this period, he actively engaged in community outreach in Limpopo, addressing the trauma and arthroplasty backlog in collaboration with the Limpopo MEC of Health and Prof. Stephen Machitse, which shows his commitment to improving healthcare access in underserved areas. In July 2023, Dr. Iiyambula embarked on an exciting new chapter as a complex trauma and limb reconstruction fellow at the Institute of Orthopaedics and Rheumatology in Stellenbosch, under the guidance of his esteemed mentor, Dr. Frans Burkholz. This aligns with his overarching goal of subspecializing in limb reconstruction, aiming to make a significant impact in this field. Currently, Dr. Iiyambula operates as Mediclinic Midstream Hospital full-time and part-time at Steve Biko Academic Hospital. Thank you so much for bringing this presentation to us. We look forward to it. So I'm handing over to you.
Thanks. Good morning, everyone. Thank you for that introduction from Ali. And thank you for everyone for joining us this morning. Thank you for the opportunity. Like Leanne mentioned, I'm a trauma and recon surgeon in orthopedics. What that means is I love putting complex puzzles together and I like making crooked legs straight. What that means is like in case of patients with a bow-leg deformity, we use external fixators to correct the legs. This was a 15-year-old male that I treated 2 years ago in George Mukari. And this was a 19-year-old grade 11 student that had knock-knee deformity that we corrected. Like Beyonce says, if you love it, put a ring on it. But today what we're going to be talking about is approach to acute ankle sprains. When Dr. Taban asked me to give a talk, I thought about what's the one thing that casualty always calls me for. And this is a call I get at least once a week, where I get called by a casualty officer, one of the referring GPs, with a patient that sustained an acute ankle sprain. The story is always the same. Patient was walking or playing sports, sustained an ankle sprain. X-rays are normal. Ultrasound shows a grade 2 to grade 3 tear. What should I do? So hopefully by the end of this talk, the audience will have an idea on how to manage these patients. So ankle sprains are one of the most common musculoskeletal injuries. They account for about 15 to 20% of musculoskeletal sports injuries. And of all ankle injuries, 80% of them are due to ankle sprains, which 77% are due to the lateral side. And in the UK, about 3 to 10% of emergency department visits are due to ankle sprains. So the anatomy, the ankle joint is a hinged joint which is made out of the talus and the fibula, as well as the distal tibia. It's stabilized by static stabilizers as well as dynamic stabilizers. On your lateral side, which are your lateral collaterals, you have your ATFL, your calcaneofibular ligament, and your posterior talofibular ligament. The ATFL is the weakest of all the three, and is the most commonly injured one. And on your medial side, you have your MCL, which is comprised of your deltoid ligament subdivided into your deep and your superficial components. With your dynamic stabilizers, we have your peroneal nerves, peroneal tendons that helps stabilize the ankle in motion. And the peroneal tendons are important when your static stabilizers are deficient. Your dynamic stabilizers play a bigger role in stabilizing the ankle joint. So when a patient presents with an ankle sprain, the clinical presentation will depend on the grade of injury that the patient that the patient has. And it's important to take a thorough history of from the patient in investigating the mechanism of injury, because that will tell you once you have a good history, that will guide your clinical examinations, because it will direct you to see which part of the ankle are you supposed to focus your attention on. With the patient having an ankle in inversion at the time of injury, you are worried about your lateral collateral ligament. And with the patient with the foot in eversion, you're worried about your medial collaterals. And you also want to ask the patient, is it the first episode? The reason being is once a patient has an ankle sprain, they're at risk of having subsequent ankle sprains if they did not go through the rehabilitation process. And you also want to find out if the patient was able to walk after the injury. Because if the patient wasn't able to walk immediately after the injury, or even in casualty when the patient is presenting, then you must think about grade 3 tear, or you think about associated fracture. So on your examination, I'm sure you guys remember from medical school, everything orthopedics is simple: look, feel, and move. You want to see when the patient walks in, when the patient comes into your office, you assess the patient's gait. How is the patient walking with an antalgic gait? Is the patient using any crutches, or was the patient wheeled in on a wheelchair? Because that will also guide your direction on what kind of injury the patient has. On the affected limb, there's usually marked swelling, and depending on the grade, the swelling will be mild to severe, mild to moderate to severe. And there's usually ecchymosis in the lateral or medial aspect of the ankle. You want to palpate the bony prominences, especially focusing on the medial and lateral malleolus, as well as your fifth metatarsal, as well as your navicular, because that will tell you if there's any underlying fracture that you need to be worried about. And you want to assess the patient if the patient is able to move the ankle, and your special tests like your drawers test and your tilt test. Those ones are very difficult to do in the acute setting. However, if a patient is presenting after the acute phase, it's easier to do those tests, and you're able to assess if the ankle is lax or not. So your clinical classification is grade 1, 2, and 3. With your ligament disruptions, they can usually be confirmed on ultrasound. However, ankle sprains are largely a clinical diagnosis. With your grade 1, there's minimal swelling and the patient is able to weight bear. With your grade 2, there's moderate to mild swelling, and the patient struggles to weight bear. But your grade 3 injuries, patients are unable to bear weight. The investigations you want to do is your X-rays. You want to do your three views. Ultrasound is not always readily available because the radiographers are not always available to do the ultrasounds, and they are not always necessary. It's not always necessary to do the ultrasound because it doesn't change your management in any way. And your MRI is not used in the acute setting. However, in your late presenters or your recurrent presenters, the MRI does play a role. So the question is, does every patient presenting with an ankle need an X-ray? The answer is no. There's a Ottawa study which they did where they have Ottawa rules. So if the patient is able to wait there after the injury, or the patient is able to take at least 4 steps in your room, so in the emergency department, they do not need any X-rays. If the patient is not tender over the bony prominence, which comprise of the distal 6 centimeters of the posterior aspect of the fibula, or the distal 6 centimeters of the posterior aspect of your medial malleolar, or the navicular, or as well as the base of the fifth metatarsal. If all those are negative, the patient doesn't necessarily need a X-ray. However, it's going to be a big challenge convincing a patient in casualty that no, I don't want to, there's no need to do an X-ray on your ankle if the ankle is swollen. Like I said, with your MRIs, they're only indicated at about 6 to 8 weeks in your chronic stage, and they are useful to exclude associated injuries, especially in these patients that are not responding to your conservative management. So when we go on to management, the gold standard of managing ankle sprains is non-surgical, whether it be grade 1, 2, or 3. And I'm sure we remember the RICE acronym: rest, ice, compression, and elevation, including NSAIDs. With your surgical management, that's once your patient fails conservative management, then there is a role for surgical intervention. With your
clinic emergency department.
Please. If we could just ask that you turn off your mic, please.
People in Zoom.
I don't recognize it.
With your management, it also depends on what type of injury, the grade of injury that the patient is presenting. With your grade 1s, they usually with analgesia, and because they're able to wait there, with analgesias and ice and rest, they are able to fare very well. However, with your grade 2s and 3s, they require a short period of immobilization, at least 3 days, and then you start with rehabilitation. However, with your grade 3s, they are usually more tender, and they can require up to 2 weeks of immobilization in a moon boot or a back slap, and followed by early range of motion. Okay, and then you also want to manage the swelling. Ice and elevation plus compression dressing to relieve your swelling. Ice packs are recommended at least 20 minutes for every 2 to 3 hours for the first 2 to 3 days. With your rehabilitations, you want a supported return to function. So physiotherapy is the mainstay of managing ankle sprains, and it stays into early phase as well as your strengthening phase. In your early phase, you are focusing on progressive weight bearing as well as regaining range of motion. Once that is achieved, then you move on to the strengthening phase, where you are focusing on neuromuscular training, proprioceptive training, strengthening those peroneal muscles to compensate for the deficient dynamic static stabilizers. And with active patients, you want to also protect the ankle during the rehabilitation phase. The patient can be in a speed brace while they're doing their physiotherapy. And whenever they're doing any strenuous activities or returning to sports, you want to have them in a brace as well. So the common question that parents ask with their kids is, when can my child play rugby again? So depending on the grade of the injury, as well as the associated injuries, and if the patient was compliant with the rehabilitation, grade 1s can usually return to sports within 2 weeks, grade 2 within 3 weeks, and grade 4 can take up to 4 weeks to return to sports. So when do you refer the patients to the orthopedic surgeon? Any patient that has pain that's not improving, because the thing is, this condition is usually self-limiting, And within the first 2 weeks, no matter what grade the injury is, the pain, if it's a true ankle sprain, the symptoms will resolve within the first 2 weeks, or there will be at least a progressive improvement in symptoms. If this is not the case, this patient, then we're probably missing something, and this patient might need further workup. In a patient with residual pain and instability at 6 to 12 weeks, this patient will also need to be referred to an orthopedic surgeon. And any patient that has the ankle, their foot feels has changed in such a way that it affects their activities of daily living, they avoid doing some sports, or they say that they can't trust the ankle, this patient might have a chronic ankle instability and need orthopedic intervention. And for surgical options, we have arthroscopic, where we look into the joint and see it's a diagnostic and therapeutic, where we're able to see exactly if there's a cartilaginous defect or any impinging interarticular defect. And you are able to reconstruct or repair the ligaments in the same setting, where you can do either an anatomical and non-anatomical repair. Okay, that's my talk. Any questions?
Thank you. Short and sweet. And yeah, just my question is that yesterday I was looking into the literature, and I mean, currently in South Africa, they look at the ankle sprains in sport less than soccer. And they found that actually there was about 66% the midfielders would have the ankle sprain. And of course, then 44%, I mean, mostly the sport people. And previously, Anna's presentation a question about actually falling elderly people. Now the question, how do you marry the two? Because now if the elderly have ankle sprain, do you think the patient have underlying medical problems, or do you think they have pathological issue, or generally just an incidental finding because of uneven or balance issues?
So it will depend on the story. What was the patient doing when the patient fell? Is it did the patient fall due to medical conditions? They fainted, or did the patient purely miss a step and sprain the ankle? So if it's if the patient missed a step and twisted the ankle, then it's ankle sprain.
I think sorry to interject, what Dr. Taban is getting at is that my presentation was concerning in the elderly. Obviously, they become, from the age of 65 onwards, they become at risk of falling for various reasons. Some is frailty, some is, a bit of sarcopenia, some of them are unstable on their feet, and that. So, but we don't always see ankle. So I guess what your conclusion is often in the elderly, is it not always a medical in a way, in many times, unless the patient is really highly functioning and not at risk.
Yeah, it should be, but the thing is, why did the ankle sprain? Proprioceptive training, like if the patient has neurological fallout, where they have things are posted, where they are proprioceptive is affected.
B12 or whatever.
Yes.
Exactly. Yeah. So they can. So then, I think it does make sense to work the patient up further to see if there's any underlying medical condition that's causing the patient to become clumsy.
I think we don't often see. The presentation is interesting because from an internal medicine's point of view, we don't actually often see people with ankle sprains.
I also don't see elderly with ankle sprains.
But one of the things, obviously, I think we do see ankle sprains, obviously, at the past orthopedics, and one of the biggest risks, someone will come with moon boot and from a DVT and thrombosis. Like, would you comment regarding the use of anticoagulation, patient moon boot or ankle sprain? I'll tell you why, because I had ankle sprain when I was in Barcelona, and because my concern was pulmonary embolism, and I was flying back to South Africa, I didn't want to go to any of the healthcare center and taking anticoagulation. So when I arrived here, my leg was double swollen because of hematoma. Now the question that, is there a role of anticoagulation in patient ankle sprain, when and how?
Not really. because with ankles, okay, depending on the grade of the injury, a grade 3 injury needs short-term immobilization. Because the best functional outcome of an ankle sprain is movement. You want to get that ankle moving. Once the patient has out of the acute phase, you want to get the patient moving. So with your grade 3 sprain, probably you had a grade 3. You also don't, if you put it in a moon boot, there is a role, especially the patient, but you also have to weigh your options, your risk factors of the patient. If the patient has a high risk of developing DVT, then it will be safe to cover them. But ankle fractures in young patients or active patients, there is usually no need to put them on anticoagulants.
I think one of the things also on your presentation for that had come out clear was about the duration when do the people goes to exercise. And I remember that I went to biokinetic and I was told that you can exercise for 6 weeks. And I couldn't really, I think after 3 weeks, if you're a sport person, you start withdrawing. And I couldn't really wait. So after 3 weeks extra when running and I was able to do my 20 kilometers. But those slowly. So the question I think you did actually highlight that very clearly there. I think 3 weeks is probably appropriate time for healing.
As long as the patient is able to wait there, as long as you start rehab as pain allows. So the less the pain, the sooner you start.
Yes. I also have a question, sorry. There's a bit of a change or drive now to move from moon boots to ankle braces. More for immobilization, rather use an ankle brace because of the mobility and comfort to the patient. I know there's a lot of physios in the area and also studies to say that it might be a bit better. How do you personally feel about ankle brace versus moon boot? Because it has quite a big impact on the comfort and the compliance of the patient.
And cost.
And cost also. Yeah, ankle brace is not cheap. Right?
No, there's the speed brace.
Yeah, speed brace.
It's the speed brace. I advocate for the speed brace. The moon boot is very expensive, and at most the patient will need it for 2 weeks. $3,000 for 2 weeks. Rather put the patient in a back slap for grade 3, and then progress them to speed brace.
But even if you say, for instance, a grade 3, can you start with the speed brace or would it be too?
The thing is, some grade 3s, or it will also depend on the patient's profile. Some patients are very finicky. They scream when you touch them.
Yeah.
That one put in a back slap.
Yeah.
The more athletic patient that can power through the pain, you can put them in a speed brace.
So my question is, I mean, this is based on the ultrasound. So the ideal is to bring the patient back after a week for the ultrasound and not have the ultrasound done in the acute phase.
You don't need ultrasound.
So now you have a patient that presents with non-weight bearing significant swelling. Right. So now we put him in a form of immobilization.
And X-rays are normal.
The X-rays are normal. Okay. So now we want to bring him back after a week. So now we go according to the clinical and we say, well, okay, this looks like at least a grade 2. We want to immobilize it. We tell them to immobilize, non-weight bearing, come back in a week's time for your ultrasound. So now the question is that first week now, because notoriously you get both patients and some doctors wants to get ultrasound done quicker, especially parents who have their kid being active in school. They want the ultrasound now. So the idea is to immobilize the patient, bring him back for an ultrasound a week later. So what's the best way to immobilize that patient in the first week? We don't know if it's a grade 2 or a 3 yet. We know it's swollen and we know it's non-weight bearing.
Back slap.
Or in lieu of a back slap with the speed brace. I think it's significant swelling.
The thing is the speed brace allows flexion and plantar flexion, dorsiflexion. The back slap doesn't allow that. So the purpose of the speed brace is to protect supine eversion and eversion and inversion. That's the purpose of the speed brace. So in the acute phase where the patient is very tender, in a lot of pain, it's not going to immobilize the ankle sufficiently. So you can put the patient in a moon boot or you can put the patient in a back slap just to help rest the foot and help with elevation and icing. And like I said, we know the natural progress of the condition. The ultrasound doesn't change our management in any way. So there isn't any, it will give the patient closure to see what kind of injury, but as long as they follow the steps of the rehab, the outcome is usually the same. They're gonna heal. And if they don't, then the ultrasound will not tell us anything more. Then we'll probably need an MRI to see why is this patient not responding like everyone else. Maybe there's an associated injury that we're missing.
But it's I find in this and interesting that you mentioned the Ottawa ankle rules. And when I worked in Canada, you got the Ottawa ankle, Ottawa neck rules, you got the Canadian C
On Ottawa, and there's also knee and
everything, because and their X-rays is a scarce commodity, and so and they've got big patient loads, so you can't just send anybody for X-rays, even less so for ultrasound. But in our community, they kind of want the X-ray. And they kind of want the ultrasound a week later.
I agree.
We've had to deal with complaints where the patient would write a big letter and say, well, why don't you send me for ultrasound that evening? So the ultrasound is nice to give them a prognostic indicator and say, okay, well, we need to immobilize you for so long. And we send this all to the physio and then they work on it.
But I think if we also educate the patients to tell them about the ultrasound, because it's an added expense. Not all patients' medical aid will pay for the ultrasound. And like you said, the ultrasound is not always immediately available. It's usually available the next day or the next week.
So now, say argument's sake, we get rid of the ultrasound and we put them in a backslide. How long do we put them in a backslide?
Maximum 10 days.
10 days. And then back in 10 days, we do a re-examination, and then what do we decide then in terms of,
Then physio.
Yeah.
Then physio. Because
Speed-based and
speed-based. Because by that time, by the 10 days, the pain that they were in, the day of injury, and the day that they come back, could be good.
I think for me, the moral story here is clear that I think we need to develop our own local guidelines. And obviously, I think once the test is not beneficial, I think if the doctors within the EC obviously need to understand that there's no added value. And I think probably our medical aid also, they're naive. So once the patient knows that they can't go to their own pockets, most of the time they will back off, because sometimes people want things because they're not paying for it because it's a plastic cut that they're swapping. And that's, I think, for me, it's a problem. If the experts say there's no need for this, then we shouldn't be doing it actually.
With us, the problem is there's no external validation. So I examine the patient day one. I tell them this is more or less what we think. We think it's just a grade 1. We believe it's going to be okay. We'll reevaluate you in 10 days. Then the patient develops a bruise. They go to a GP. Another doctor has been a GP for 50 years longer than me. The doctor says, oh my soul. They missed your major injuries. Not only that, now you have blood clots in your foot. That mommy writes 5-page letter to the HPCSA explaining that night how insensitive and stupid you were. Because now her GP that they've been trusting for 5 decades told them about the blood clot I missed, the child's severe ligamentous injuries. So I have to say that sometimes you need an external confirmation, which does help to give those certain patients that closure that they want, because they count down the minutes to your 10 days and they count down the minutes to your 2 weeks immobilization. They count down the seconds to when they can drive again or get out of the backslide. So it's a little bit more complicated than just focusing on the injury. You see the patient, the mom, the dad, the coach, the physio at school, and the GP.
Yeah.
There's a lot to deal with.
What I can allude to that, most of the patients actually that got ankle sprain then develop venous thrombosis are patients that actually not that they have other risk factors, either heterozygous thrombophilia that were not previous pickup, and then probably the ankle sprain become the presbytum. So it's not that probably is the ankle sprain that lead to it, but because of underlying process that's already been there, but they've been stable before. So I think that the truth that we don't need to obviously agree with you that anticoagulation probably is not indicated, provided the patient is mobile. But if the patient is not mobile, the patient obviously got risk of obesity, BMI more than 25, that increases the risk of of the DVT, and also if the patient is going to be driving around longer, more than immobilization, that's more than 6 hours, that also require a bit of anticoagulation. But if they have none of the above and no underlying thrombophilic risk or whatsoever, then I don't think there's need for it. And even after some, then there's no benefit. But in obvious, those need to be documented, and hopefully, perhaps as a casualty doctors, is to have probably clear kind of guideline with obvious risk profile check and make sure that actually they're documented. Because they go to an SPC and then they look at what is there. The issue that we can't predict what's going to happen tomorrow, but we can predict we can use the knowledge from yesterday to predict what's to connect the dots going forward.
I just think the protocols in a big city center versus a rural community with scarce resources practically is different. The expectation there is different. In our city, like Bianca says, we need to be evidence-based and we need to be practical at the same time. It doesn't help you decide, and Canada is very evidence-based, doesn't come hell or high water. You want your ultrasound, you're not getting your ultrasound, period. You can't go anywhere else. In South Africa, there's that they go somewhere else where they get told, oh, your ligaments are torn. Oh, they missed it. The implications, there's no practical implication for that.
Yeah.
But that's unfortunately what we deal with.
Yeah, unfortunately, we're forced to be defensive.
Yeah, but we can't control. No, we can't control what people say. We can't control people's perception, opinions. Human being about our opinions. That's a reality. But I don't think that's what distort your practice as a good clinician. You obviously, I think, but obviously, the lively thing, make sure that you always work in consultation. With Uncle Spring, I mean, you got Dr. Iiyambula is around, available 24/7 for opinions, and obviously speak to him when it's needed.
Now it's going to get even more fun.
It's always available. I think that's the idea. That's why we have expertise. And then obviously, I think within the casualty officers and orthopedic department, we can create kind of way. How do we actually make sure that we can educate our patient better and maybe come with drawings and maybe more patient with leaflet and or with flyers to make sure the patient well educated. And obviously, I think one of the things which is, I think, provides casualty officers, I think there are patients out there who feel like, okay, you just a casualty officer is not good enough. I think sometimes you could say, listen, you can go and see the specialist at outpatient, get your assurance there and all those. If you want, then you go high level, obviously you have to pay fee for that. And then at least provide a given assurance. Doesn't go to the GPs because most of the medical legal issues come from colleagues. It's never from the patient. It's colleagues that actually say things to others. Exactly. So I think don't be afraid to actually refer the patients to the outpatient clinic with the orthopedic surgeon, and then at least he can tell him, listen, this is what it is, which come from what you already know. Then I think perhaps that calm them down because once they hear specialists, they're more calmer than actually when they say you're just a general practitioner. And obviously most of the GPs sometimes they think like they're more better than you, something like that. And it's human nature.
We all have our little niche.
Yeah.
Well, I think the one thing that this lecture kind of emphasizes, we don't have to have this anxiety of an ultrasound showing a grade 3 sprain. Well, let's call ortho and ask. So the bottom line is the patient is not better after 2 weeks. Call ortho if he's got that instability after 6 to 12 weeks of recurrent injuries. That's the indication. So I think that's
when you get worried.
That's the kind of helpful guidelines that we can implement. So the doctors don't get this nervousness. Should I call ortho? Should I not? You know, if it's a break, fix it. If it's not broken, give him a brace and
put the ring on it. And then, guys, I think our doc here have new addition in the house. I believe so. You take time lucky, isn't it?
Yes, sir.
So we just have a small gift for you to just say thank you from us, the team. Once the service